GLP-1 agonists are everywhere, but are they really all they're cracked up to be? Or is the ground going to open up beneath these blockbuster medications? Let's find out. This is part 1 of 2 with Dr. Sean Wharton, who has his doctorate in pharmacy and medicine from the University of Toronto in Canada. He practices internal medicine and is the director of the Wharton Medical Clinic, a community-based weight management and diabetes clinic. He's an assistant professor at the University of Toronto and adjunct professor at McMaster and York Universities. He is the lead author of the 2020 Canadian Obesity Guidelines, which has been recognized around the world and has published many peer-reviewed articles in international medical journals, including lead author on several New England Journal of Medicine articles. Dr. Wharton is also involved in advocacy to achieve health equity in medicine. Again, this is part 1 of 2. You're listening to Succeed in Medicine, the show for practicing physicians who want to master the parts of their career and life that med school never prepared us for. From interpersonal skills to career navigation to the essential information every physician needs. I'm Dr. Bradley Block, and in every episode, we bring you brass tacks advice and immediately applicable insights from world-class experts, so you can feel prepared wherever your MD takes you and build a life in medicine that's sustainable, rewarding, and actually worth all those years of sacrifice. Dr. Sean Wharton, thank you so much for being on the podcast.
Absolutely, Brad. It's really good to be here. It's a great podcast.
Thank you. We're going to be talking about the GLP-1 agonists. And I think the interesting part is these medications have actually been around for quite some time. And yet recently they've exploded in popularity. And so the whole drug companies come up with these medications to sell them. And yet this was like a sleeper. So what happened?
And so it wasn't a sleeper for us, the ones who have been involved in the field. We were very excited when the GLP-1s came onto the field for type 2 diabetes. And so this is from 2009 or so, 2005, 2009, they're talking about them and then they finally get onto the market and they're good. But the SGLT2 inhibitors are also here. So they're blockbusters. They're making it's a pill, easy to take. Your glucose goes down. The GLP-1's an injectable once a day. And it's like, yeah, these are good, but not a blockbuster because diabetes is well controlled. Things are pretty good. If you can't control diabetes and you're a doctor in a first world country, we have a problem. And when I say first world, I mean the first world, not Southern United States, which is not the first world.
Ooh,
but I will say it.
Okay.
If you're a Black woman in the Southern United States, the chance that you're going to get appropriate and good treatment is a challenge. The poverty down there and the lack of access to care is problematic. So when we talk about the forgotten and the missed population, it's the indigenous and it's the poor and socio-demographic group, oftentimes in the Southern United States. So that's what I talk about. I talk about that a lot. So you'll hear about that a lot on the podcast. Who isn't getting this and why it's a problem, why the field has to change with this blockbuster. So it feels like it came out of nowhere. So the 2009, 2010, we were starting to use it. It's making it a big deal. And then we discover that, of course, you're losing weight in the type 2 diabetes world. And then could you potentially use this in people who don't have type 2 diabetes? So the first company looking at this, Novo Nordisk, the people down in the lab are like, you know what? I don't think we should do this. We shouldn't do it in people without diabetes. Or the people at the higher level, where their people in the lab are coming to them saying, I think this works. I don't think there's a market. We're an insulin company. And then they kept on pushing and pushing. And they said, okay, let's give it a shot. In words like gangbusters, it's just incredible. We kept the first daily injectable and they really changed the market. And then the weekly one. And the big deal was Elon Musk and I don't know, whatever her name is, the other superstar in Hollywood who took it and then end up losing weight. And then everybody's taking it. The whole world wakes up all of a sudden, not just America, but the whole world wakes up and discovers about weight loss.
This was like a serendipitous side effect of the medication, right? You use it in people with diabetes. Some of them end up losing weight. It's like a smaller percent because the dosing is different, right? For diabetes versus obesity.
Correct. Yeah, the dosing is different. So people with type 2 diabetes lose less weight than people without type 2 diabetes. We don't know why.
On the same dose.
Correct. On the same dose. They lose about 5% less. So every study that we ever look at, every new drug that we look at, if the drug is a 20% weight loss in people without type 2 diabetes, it's going to be 15% in those with type 2 diabetes, about 5% difference every single time. What's the reason for that? We don't know. Is it the beta cell? Is it something to do with the brain? Is it something to do with glucagon? Is it a hormonal thing? Is it that there's more men? Men tend to lose less weight with medication than women do. So in many of these trials and diabetes trials, there's more men. There's about a 50-50 split. In weight management trials, it's about 75-25, or sometimes 80-20, more women. So those trials look better. So there's all of that wrapped into it, but really we think it's a biological reason, and it may have to do with estrogen, testosterone, all kinds of different things, but we don't know the reason.
But isn't the dose different if you're using it to treat diabetes versus using it to treat obesity?
Correct. The dose is different. So we're not talking about a dose difference when we're talking about the weight change difference, because every single weight management drug, we've tried it in patients with type 2 diabetes at that dose. So semaglutide 2.4 milligrams, which is the Wegovy, we've done it in people with diabetes and without diabetes at 2.4 milligrams. The tirzepatide, the Mounjaro Zepbound molecule, we've done it at 15 milligrams of people with type 2 diabetes, always a 5% difference on the exact same dose.
As an aside, I just used the word obesity, and I know this is something that you discuss, right? And we've done episodes on this, right? How to talk to people about weight, as it is very triggering. And we know in healthcare, we do it really poorly, right? We can do this a whole lot better. So when you're saying, well, what is the indication for this medication in the population that doesn't have diabetes? Are you using the word obesity?
Yes. Yes, we're using the word obesity. So we use the word obesity in the field, and the field's different than the general public. We use the term obesity when we're talking to other medical doctors, when we're talking about the actual disease state. So it's when visceral adiposity causes an impairment in a person's health. May that be causing type 2 diabetes, causing osteoarthritis, causing fatty liver, causing coronary artery disease, or even causing significant psychological problems. And so if you've had rapid weight gain, if you're at fear of getting into a higher dose, if your food noise is driving you crazy, you can't focus and concentrate on a meeting and your family, that's disease. And maybe it's been caused by that inflammatory process. And so that is what obesity is. So if you have a BMI of 32, and that's considered in the obesity range, but you're an African-American woman and you have hips and curves and you don't have any central adiposity, for whatever reason, you just have the hips and you have a small waist and you don't have any prediabetes, don't have any osteoarthritis, you should not be called somebody living with obesity or somebody with obesity, although the definition is that way. You should be called beautiful. That's the definition for that person, is beautiful. And they're great the way that they are. Obesity is reserved for the disease state. People will use these drugs for all kinds of things, but when we, the internal medicine doctors, talk about, we're talking about obesity as the disease.
So you could have a couple of very similar people. So what it gets down to is, as with many things, it's nuance. There's a nuance here, like whether or not it's considered obesity. It's that you have to be carrying extra adiposity, but specifically centrally, or can the weight distribution is, you were just using that as an example.
Yeah, as an example. So if the weight on the knees is significantly elevated, that's pushing and causing osteoarthritis, and it's a compression thing, then it's not just the visceral adiposity, but it's actually the actual weight also. That usually doesn't happen at a BMI of 24 and 26, unless you're much shorter. So you can see that it's a combination of things. So that's why we want the number of diseases that are caused by the adiposity. So we don't always just call it the visceral adiposity, but just the adiposity of the weight. And that causes any of the 200 diseases that are potentially out there impacting. Some of those are weight ones and some of them are metabolic ones. And so whichever one, you can call it obesity. Yes, it is a nuance, but as doctors, we should have that flexibility, that capacity.
You mentioned the term food noise, which is something that I had never heard of until these medications really became popularized. And now it's something that my wife has suffered from, and she talks about it and she gets it, right? But for those of us who have never suffered with it, it might not make so much sense. So can you describe what food noise is?
Excellent. Food noise is really the roots of this entire problem. If you don't have food noise, if you don't have cravings, if you don't eat beyond what the body particularly needs, then you don't get obesity. So any treatment of obesity, it has to treat the food noise, or the cravings. We called it other things previously. We called it cravings, and my satiety is in there, and I'm binging, not necessarily binge eating disorder, which is a psychiatric disorder, but just so ravenous and having so much food and doing that maybe a couple times too extra. So those kind of things. We've started to call it food noise now, although we called it everything else previously. So think of it as anything that drove you to eat a little bit more than you did previously. I got an addiction for this candy. I got addiction for chips. I can't stop drinking pop. This is terrific. I love it so much. I don't know why I can't stop. That's food noise. And it's more specific now that we talk about things like it takes up real estate in your brain. So if you're the person that sits close to the edge of the row while a presentation's going on, so you can leave first, you can escape, and you can get into your car and drive through and eat a bunch of food and then go home and eat dinner as well. If you're that type of person that can't even focus because you're thinking, when is the next meal? That's a food noise. When you're going to sleep hungry, when you've already eaten, and you may wake up because you can't focus. You're talking to somebody and you have a smell of something delicious or think of something delicious and you lost it. You've just lost the focus. You don't know what that person's saying anymore because you're just thinking about food. That's food noise. Takes up so much real estate, so much capacity. That's frustrating for people. And if you can quell it, you're on your way to treating obesity.
Yeah. For her, that was a major thing. It would occupy so much of her mental existence that it was always something. If it wasn't in the front of her mind, it was in the back of her mind. It's something that I didn't appreciate. Being married to someone who, it's given me a lot more empathy for people in these situations that has something like that. I understand it a lot better after, because I live with someone who goes through it. Now she helps me get it. It made it hard to concentrate on other things.
And can you imagine how intense that food noise becomes when you've lost 5 pounds, 10 pounds, 40 pounds? And the thing is, why would the food noise ever go away when food is survival? You have to eat. So when you have alcohol addiction and a number of other things and heroin addiction, eventually it goes away. It gets better. It may take a long time. You may need methadone. You may need all types of treatment, but you don't need heroin to live. You don't need alcohol to live. So therefore, God, whoever she is, decided that this food noise cannot go away. It can only get louder and louder and louder. So if you're somebody at year 2 or 3 that's lost 30 or 40 pounds and keeping it off, your food noise is extremely loud and you've somehow been able to manage it. You're always hanging on to the edge of the cliff and you're managing 2 things, managing your job, your life, and this food noise all at the same time. And the majority of people can't do those 6 things all at the same time. So that's why the majority of people fail, because the food noise is just too loud, because it's biological and God gave it to us.
And the GLP-1 agonists, they quiet that food noise. And so does it really work if you need to go back on? Well, of course, most of these, you're going to get pushback like that from the public, but you're not going to get pushback like that from a physician, I would hope, because the food noise is part of the disease state and you're treating the disease state. Your cholesterol goes back up when you go off your statin. Like, of course, your blood pressure goes up. Why would we think about this any differently? And yet somehow the lay public does. But this isn't just another example of why you would need to continue on some dose of this medication indefinitely, because this is part of the disease state.
Right. Why you would stay on it indefinitely if you want to quell that disease. If you've got no issue with the disease coming back and the person's going to try to use willpower to deal with the disease or cognitive behavioral therapy or do whatever, then that is okay. Go forward and do that. But don't pretend that you're not taking a stopper off. And once you do that, they have to stop that spouting water coming up with some other method. And some people have other methods that they can sometimes use. So I let people stop if they need to, because they need to do it as the food noise come back. It's so you can experience it and feel it, because we've got the stopper. We can put it back on that spurt that is coming up. So that's the way I try to explain it. But this question of why won't it stop? Why can't I stop the medication and just keep the food noise off? I just needed that to help me to get there, and then everything should be fine. It doesn't just come from the public. It comes from every doctor conference that I go to.
That is
everyone.
Disappointing.
And it's oftentimes the first question. And I have to address it. You really have to address it. Although you're addressing it over and over and over again, you want to get to other more nuanced questions and more interesting questions and more about the biology and the metabolic components and some of the other interesting things. Maybe that fixes Alzheimer's and addiction in the brain. And I want to talk about other stuff, but I have to talk about this, because they always ask it, because I think doctors are people too. and we've been bamboozled. We've been biased. And I think doctors go to Vegas. There's some doctors go to Vegas and think they can win. Good too. Yeah, because they win every once in a while. Oh, look, I won. So I think I can actually keep on winning. Well, that's not how Vegas got built. When people are losing, you're going to lose. But because we get some wins with obesity medicine, we get these people on the front of magazines that got to win. You yourself had to win for a little bit of time using willpower and videotape and I don't know, Jane Fonda or something like that. And you want to win. So you figure that your confirmation bias is that you were the problem and that you can get that win again and just sustain it better. Even doctors get bamboozled by the confirmation bias. The front of people's magazines. See, someone can do it. That's why I answer the question, because we're human too.
If you like this podcast episode, you're going to love the podcasts over at the Doctor Podcast Network. For instance, Telemedicine Talks. Telemedicine is revolutionizing healthcare. Dr. Lee Damasco and Phoebe Gutierrez, Telemedicine Talks, bring you to the forefront of this digital transformation, featuring insights from pioneers and practitioners. Stay ahead of the curve, subscribe to Telemedicine Talks, and navigate the future of medicine with confidence. That's a good point. That's an excellent point. So I should stop making those assumptions. Well, you're speaking to a physician audience, so of course we know this. No, okay, we need those lessons too. Speaking of lessons that physicians need, how about a little review of biochemistry? These GLP agonists came out when I was well out of medical school, and so this is all new to me. As an otolaryngologist, it's not going to be on my upcoming board refresher exam. So, although Mounjaro might be, but we'll talk about that later. Sorry. So,
yes, Mounjaro was the one that got the indication. Okay, so correct. So
give us the short version of the mechanism of action of the GLP-1 agonists.
Excellent. So incretin, it was a new thing that came out about 20 years ago, where we knew that there always had to be some kind of hormone that told your body that food went into your body and release insulin and then stop eating. So there had to be a hormone, but we didn't ever know what this hormone was. And it eventually looked like glucagon. So that's why it looked like there was something out there that was a hormone that looked like glucagon that could potentially be it. So eventually they figured out it was glucagon-like peptide. That's why we called it that, because it's this big protein and it goes from the gut over to the pancreas to have the pancreas beta cells wake up, start producing insulin, grab all that food and put it into fat storage so we can save it for later so we can go to sleep and we can get sugar, stay away and go to the brain, tell the brain to stop eating. This person's had 2,000 calories. That's great. So what someone had to do then was isolate the receptor on the pancreas that was actually collecting the hormone and turning on insulin, shutting off glucagon and telling the brain not to do that anymore. So Dan Drucker, the scientist in Toronto, Canada, came up with isolating the receptor. He's going to get the Nobel Prize next year, he and his team. Right. And they lost out to the mRNA vaccine guys, understandably. And so isolating the receptor was the first part. And then a bunch of smart people at companies, Novo Nordisk and some others, developed the actual molecule that could fit into the receptor. And those are big peptide molecules. They're like insulin. Insulin's a big peptide. It's a lot of Daltons. So you have to do it as a injection. If you give it as a pill, then it gets degraded in the gut and you can't go across the gut barrier. So it's an injection. So these were injectables also. They're a little smaller. So eventually we're going to talk about how they got into being pills because they're a little smaller, right? But the injectable form is the kind of the better form. And as a result, they found out that giving a higher dose, think of it as if you give the injection, give a small dose because it only has to go from the injection site to the pancreas to work on diabetes. So the bottom line is people with diabetes and people with obesity don't have enough GLP-1, just like thyroid hormone. If you don't have enough thyroid hormone, what do? We give you some exogenous thyroid hormone. People living with obesity and type 2 diabetes don't have enough GLP-1. So we can use something called a DPP-4, which is an enzyme that stops the breakdown of our own GLP-1. So our own endogenous GLP-1 gets a little bit stronger just because we stop the breakdown of it. Those drugs were a big deal. Januvia is the classic name of that DPP-4 because not enough GLP-1, our own endogenous GLP-1 wasn't allowed enough. So small amounts to get to the pancreas, bigger amounts to get through the blood-brain barrier.
Got it.
That's why the dose is different. You're just not going to get enough by inhibiting that enzyme. And you needed to get even more than what the injectable dose for diabetes was. So we gave it 2.4 times more and you got it up to the brain and then it started to actually work. So that's the science of it. That's the beginning and the end of it. And then once it got up into the brain, it did a bunch of things in all the different areas of the brain. We don't know which areas because the brain is the strangest place in the body. We don't know what's going on there. In general, we know that there's a center that controls weight regulation. It's the MC4 area, it's the PharmC area, and GLP-1 works in there. A bunch of other things work there too. But for some reason, this one worked really well, really nicely. It was like a unicorn. Like somebody injected it worked really well. It didn't cause a lot of side effects. You're like, there's 100 other things and that could have an injection, but it caused high blood pressure. It caused this, it caused that, it caused all these other things. For some reason, this one didn't cause any real problems, went up into the brain, worked sensationally. This unicorn happened, and that's why it exploded.
And so there are some like serendipitous other effects that we're finding, right, of this medication. Like you had mentioned, Alzheimer's, I saw it improved COVID outcomes. I would imagine it helps because the people had a lower BMI to begin with, because we know the higher BMI, the more likely we are to have a negative outcome. So I'd like to get into the separating fact from fiction portion of the interview. So first, if we could get into some of those serendipitous side effects, and then we'll dispel some of the misinformation.
Yeah. And the reason why I should back up on this is because when you get rid of visceral adiposity, all your interleukins and your TNF alphas and all of your adipokines or cytokines end up decreasing. And those things cause problems. They cause COVID virus to attach better and to make you sicker because you've got all this other inflammatory stuff happening. Get rid of the inflammation, things end up getting better. The challenge is the only way that we've ever been able to get rid of inflammation is monoclonal antibodies or steroids or losing weight. And the challenge is that the losing weight, because everything got better when anyone loses weight, right? Again, I'm old, so you go on the Jane Fonda program or the Richard Simmons program. Yeah, you lost weight, your life got better. Everything got better. Joints got better. Sleep got better. Your life got better. Problem is it didn't last. And that's the only thing that we didn't understand is how to keep that inflammation down, that HSCRP, that ESR down. And these medications were able to keep it down for longer than a minute, longer than 3 months, longer than 6 months. It's up to a year and a half, 3 years, 4 years. So coronary artery disease got better because the inflammation stayed down. You would have always got, if you could get a diet that kept somebody's weight off for 5 years, you get the same effect. Pretty close. You should get the same effect. That is where we think that a lot of it is. A lot of it is keeping that inflammatory components down. Some people think the actual drug itself is having some anti-inflammatory effect. The same way we think anti-lipid drugs themselves, not just the LDL going down, but the drug does something to smooth out the vessels and a number of other things. So many people are looking into that. Does the molecule do something? I'm more on the side that the inflammation from visceral adiposity and keeping it down, even if you had a small amount, that small amount was causing some kind of problem, and get rid of that problem and keep it gone. Think of anything that has inflammation in it, keeping your weight off. If your weight was a problem and visceral adiposity was a problem, keeping your weight off will make that thing better.
That makes a lot of sense.
And we can name 200 of them. We can name any 200 inflammatory conditions that are out there that definitively makes it better. And the ones that are dealt with BMI, the actual weight, that makes it better too. And it always did. You lose a bunch of weight, your osteoarthritis gets better. Unfortunately, you regain it. Your osteoarthritis back to where it was before.
And now we have something that we can offer. Previously, it was like, well, if you lose weight, and then the patients are turned off by that because they're like, well, I know I need to lose weight. Now I'm hearing it from the doctor. They're not teaching me how. And now we can say, listen, I recognize we've had this discussion before. I know you've tried these things and you haven't been successful at keeping the weight off. How would you feel about trying this? Like previously, the conversation was just over. Go home and try and lose some weight. And then they're turned off to us. They don't want to see us anymore. And now we've got, okay, let's try this. And so there are a bunch of different ones out there. And so those of us who are naive to prescribing them, the majority, the Ozempic, what are the differences between them?
One, I'd say, first of all, Bradley, the way that you said that was brilliant. We worked on that sentence structure for a very long time, and you said it exactly the way that many of us have worked to get this into the appropriate lexicon. Way that we treated obesity in the past was not effective, and the way we spoke about it was not sensitive. We now know more, and we can treat obesity much better. are you interested in having a discussion about these treatments? That sentence took a long time for us to come up with to make people understand that it's the grand apology, it's called. You gave the grand apology. You weren't even aware. So we call it the grand apology. And you did it. I can't believe it. I mean, it's the first time I've heard somebody like do it without knowing all the stuff that we actually do. The grand apology is, I apologize for the way that I treated obesity in the past by telling you to eat less, move more, whipping you, shaming you, and blaming you. I apologize for my colleagues who did that. I apologize for maybe the orthopedic surgeon that just did it to you and told you, you need to lose a bunch of weight before you get that knee surgery, and then sent you on your way. Meanwhile, you're a 45-year-old man, 55-year-old man, you've done it multiple times before. You're not an idiot, but he just treated you like one, or she did. That's what everybody gets. And you just explained it nicely. And if we didn't have the medications, we should still have been able to say that the way we treated in the past was not effective. We still don't have any effective treatments, but I'm here for you for compassion and to help to the best it possibly can. And maybe you do need a new knee at a BMI of 45, and the surgeon can do it. They're just being biased, because I know they can do it at that weight of 300 pounds. You can get on the table. It's not going to be easy, but they can do it. And now the next thing is that why should we be giving a script for it, and how should we be giving a script? I think just about everyone who is in medicine, family medicine, internal medicine, if there's a disease that you're treating that's affected by this, this is going to be an effective treatment for that patient. You don't have to push it on patients. You just have to invite them. So it's called ask, listen, summarize. So what I'm hearing is that your knee has been in pain for a long time, and you believe that weight is a part of it. And you've tried a lot of times and it's been really hard. Would you be willing to hear about some weight management options that may be effective? And then you wait and they say, yes, I actually would. That you've invited them to hear something specific. If they say, no, I'm not interested, I don't want to hear about medications, I then say that if at any point, if you're interested in hearing about this, let me know, because we now know more.
Don't push. You'll burn that relationship.
Exactly.
If you just invite and they're not interested, move on. Yeah.
So we're now in a position where patients frequently know just as much as we do about the titration schedule, about the side effect profile, about what to expect, about how to move forward with it, and about all the benefits that end up happening. We're still the doctor. We're still in charge. We're still guiding this, but they have a lot of knowledge. They've got a lot of podcasts they can go to. They've got apps that they can use that can talk to them and teach them and help them. It's absolutely wonderful. So I think we're in a position where we shouldn't be afraid of giving these injectable medications to people who truly need it. They're trying to get into a bikini, if they're trying to just get into a wedding dress, and if they're living with obesity, then you should still give it to them. If they're doing it and they have a BMI of 18 and they have food disordered eating and they have bulimia, they have some specific issues. Well, granted, this doesn't cause bulimia. It doesn't cause food disorder, right? If they had a mental health disorder, they have mental health disorder, but this doesn't cause it.
Thanks for listening to part 1 of 2 with Dr. Sean Wharton about GLP-1 agonists. Stay tuned next week for part 2. Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means either you fell asleep or you really liked the episode. So please write us a 5-star review, take a screenshot, and email it to me so I can send you a quick guide on how to earn patient trust in 20 seconds or less. Email me at brad@physiciansguidetodoctoring.com and feel free to suggest a topic or guest. I take your requests seriously. The views expressed on this episode are those of the interviewer and the interviewee and do not represent the views of their employer or even their significant other. Even though the magic of podcasting makes it sound like I'm talking directly to you, this is not a doctor-patient relationship, and this is not medical advice, or financial advice, or legal advice, or really any advice. Thanks again for listening to Succeed in Medicine.